Good morning, everyone. Welcome to another monthly webinar series. Um, Hey everyone, welcome to another monthly webinar series. So before we get started, please keep your microphone muted during the presentations to minimize distractions. If you have any question, please raise your hands. Remember that this is being live streamed before we get started, please keep your on YouTube, and it will be available on YouTube after the event. So if you do not wish to be seen, please just make sure to keep your camera turned off, and leaving your camera on indicates that you are agreed to be streamed in public. So we offer these webinars every third Thursday of each month, 10 a.m. New York time, and which is 8 hours ahead of EAT. Today we have Dr. Magalie Cadieux with us. Um, Dr. Cadieux is originally from Montreal, Canada. Her journey in medicine has been a remarkable one that reflects her dedication to global health, education, and innovation in neurosurgery. During med school, her perspective on global health was broadened by her experience in Bolivia, and that ignited her commitment to international collaboration. She then went on to complete her neurosurgery residency at the University of Calgary in Alberta, Canada. And while in residency, she pursued a master's in medical education at Harvard Medical School. This is something that propelled her into impactful work within Canadian neurosurgery residency programs. She's passionate about spine surgery, and this led her to complete a fellowship at Washington University in St. Louis. She then extended her expertise globally by joining Weill Cornell Moy, the Tanzania Neurosurgery Partnership. And during her time in Tanzania, she made significant contributions, including advancing the use of spine navigation among local surgeons. She's now back in St. Louis, where she serves as assistant professor of neurosurgery at Washington University and the medical student clerkship director. We're thrilled to have Dr. Magalie Cadieux today with us to take us on her journey on introducing new technology in a low and middle income country. Um, Thank you, Dr. Cadieux.
Thank you, Anthony. Thank you, Anthony, for the introduction. Um, I will share some slides whenever I can, and then I can start this presentation. That's interesting because I had a very difficult task actually to follow these amazing speakers um, that are Dr. Hartle, Dr. Mengat, and Dr. Paul Young. And I feel like this December, my I don't have the breadth of experience that they all have regarding global neurosurgery, but I think that my contribution was small enough that I'm very, very grateful to be invited to the Global Neurosurgery Roundtable today. Um, so yes, today I'm going to talk about introducing spine technology in low and middle income countries, but truthfully, that would be the experience in Tanzania and what we were able to accomplish after 1 year basically of trying hard to get some new technology over there and how the results have become to be something permanent now. Um, my only disclosure is I'm a neurosurgeon with spine subspecialty at Washington University in St. Louis. Like Anthony said, I do not have any royalties or anything like that within the company or the brand names that will be presented today during the presentation. Um, so as it was mentioned, the partnership between Weill Cornell Medicine and Muhimbili Orthopedic Institute is one that has been ongoing for a long time, and I was lucky enough to be part of it from July 23 to 24. So for a full year, I was the fellow over there, and my mission that was given to me for this fellowship particularly was to make use of the spine navigation system that had just arrived in the country at this particular institution so that it can be used adequately, and used in a way that it will provide increased and better patient care. And this here is Dr. Shabani and Dr. Romani Sabas as well, which were integral part, basically, of the whole project and the whole mission to get the Brain Lab spine navigation working over there. So how it all started actually was that the CEO of the Right Brain Foundation, which is a branch of that Brain Lab company, which is a German company, decided to actually be involved within this donation program, where it involved a Brain Lab Kick 2.0 spine navigation system to be donated to the institution in Tanzania. So that donation happened to arrive at the Global Neurosurgery course in March 2023. So that's, if I'm not mistaken, a machine that is probably around $1 million, but that is useful and is being used elsewhere in the world. So then the goal was to make use of this machine in a way that patient would actually benefit from it. This is what a Kick 2.0 spine navigation looks like. So you got here a camera that is quite small, actually, when you place that in an operating room. So in terms of capacity of location and capacity of where it can be in an operating room, that was not that much of an issue. And here you had a screen where you can have screw planning and visualization of the whole spine from a CT scan. It's even a bit smaller in terms of at that base here, the one that they got in Dar es Salaam, which at the end of the day does not take much place, and it's very malleable and movable in an operating room. So that here is how you're able to plan some screws in the patient so that your screws are always very accurate. The rationale behind why to get this kind of machine as a donation in Tanzania was that based on the Neurosurgery Tanzania project that happened with Weill Cornell, there was a lot of epidemiology studies that have been ongoing since, like, we're talking 2015, if not earlier than that. And the spine trauma in the country of Tanzania are very, like, there's a large number of them. And a lot of people get surgery based on their spine trauma. Now, there's this need for stabilization when you get into a car accident, when you fall a tree, when you have an injury from just like even like in a boat or something, right? Because it's close to the coast. Well, you do need implants. So the donation machine needed to be one that could be compatible with any kind of implants. So in that part of East Africa, the implants or screws that are available are not necessarily the ones that are the same that they have available in Europe or in North America. And even if the machine was from one of those places, it needed to be compatible with whatever is available in East Africa, which most of the time were screws coming from either China or Turkey or India. And at the end of the day, they needed to be used anyway for the patient. And the other rationale is that why not can the patient in Tanzania receive the same kind of gold standard that is available in other parts of the world, meaning navigation, right? So a lot of studies in the literature have shown that by using navigation to place screws in somebody's back, increase the accuracy compared to like any kind of freehand placement where you're just like knowing the anatomy, or compared to any fluoroscopy where you do an X-ray to see the anatomy of the patient. So that was the rationale behind why this donation was adequate, was needed, and was a plus for the institution. This is all a small amount, actually, of literature that shows that navigation compared to freehand technique for pedicle screw incision, or compared to fluoroscopy, or compared to anything else, is much better, right? Increase accuracy, you have like a 99, 98% of accuracy based on your screw placement. What does that say and what does that do? That means that the patient most likely will not come back for another surgery based on their screw placement. And that also means that the patient will not have screws that are misplaced either in the canal or either in the nerves or anything like that, because the navigation will have been accurate. So that is where it's coming from, and there's evidence for it. Now the numbers, right? Here we see how the brain lab is being used. The surgeons here look at the screen, and we're utilizing these navigated tools that are registered with the screen itself. And we see it here at the same place. Those tools here are being navigated. So numbers, well, when the brain lab spine navigation arrived in 2023, in March 2023, unfortunately, only 6 cases had been done over 4 months, which 2 of them have been aborted because it just didn't work. The machine didn't work, no navigation, it was inaccurate, nothing was happening. It was not great. And that's very important to know, because then behind that, there's a reasoning that you need to try to figure out, why does that happen over there? And why are we okay utilizing it in North America or Europe and there's no problem? So here comes the learning curve of how you can introduce technology in spine, yes, but also in cranial or any kind of other technology in the low and middle income countries, where necessarily this technology is a complete new thing that wasn't there before. So the phases of introduction that happened in Tanzania were related to like the global neurosurgery course that happened, the previous fellow attempts for cases, the current fellow, which was me at the time, that was attempting for cases. And then we made some new changes and everything worked at the end of the day. So if we talk about the global neurosurgery course that happened, that one was in 2023, but there's also the one that happened in 2024. So that machine here, well, during the course, they brought over to help everybody the representative of the company. So somebody who is like very, very familiar with that company and that device was there on site in Tanzania, giving tips and tricks to everybody as to how to utilize the machine properly and make it something great. Now, in 2023, when this happened, I believe around 6 cases with the machine were done and everything went smoothly, everything went great, everything was perfect, everybody was utilizing it, no problem. But as soon as this rep left the country and left the machine, obviously it was more difficult to understand how to use it when you were left by your own, right? And so that's when only 6 cases were booked over 4 months. Now, how to get there, right? How to get to a point where you use the spine navigation and you place your screw in a way where it's going to be always the standard for every patient. Well, part of what we did is we did a qualitative analysis, right? Meaning that we sat down with people in Dar es Salaam with the help of Dr. Romani to try to figure out, okay, so what is the actual problem with this? What is the root cause of why we cannot use it here? Then we did thorough observation of the cases as to what was the problem when you're in the cases to try to remediate that and make it better. And then we built a team. We built a team that was motivated, that needed to be there, and that had the same mission as me, which was making sure this technology would become the gold standard in Tanzania, in that institution. So the qualitative analysis and the interviews that we did were interesting. So what we found is that there was this learning curve. People talked about it, this learning curve, and they were talking about the fact that people should understand that there would be a struggle at first and that to not get discouraged. There was this understanding that using spine navigation would minimize the use of X-ray so much that it was perfect and we should use it and keep using it because it was advantageous for the patient, but also for the surgeons. And there's a lot of surgeons in that room in the Muhimbili Orthopedic Institute. So you don't want everybody to be radiated too much. And then they were also understanding that the attitudes towards using this new technology was kind of like a little bit low, not necessarily positive at first because it was taking a long, long time to do the surgeries based on how they were utilizing it at the time without a rep and without somebody who was fully trained on that machine. So we went in, and based on that, we went and observed all those cases. And here in phases 2, 3, and 4, and 5 of the learning curve, we can see that we did some collection of data regarding as to how did the screw placement and the length of screw placement had an evolution over time. So over here in the phase 2, that is when the rep from Brain Lab left the country and left the machine to the previous fellow other than me and with the people, the surgeons over there in Tanzania. So 4 cases were actually done. And to do these 4 cases and putting 6 to 4 screws in those cases, unfortunately, it took over an hour and 30 minutes per overall screw placement, which is way too much because most of the time it takes about 30 minutes for people to put screws, right? So that was very, very too much. And I can understand why when we went and interviewed these people, they were like, well, it takes way too long to use that machine. We don't want to use it anymore, right? Now I came along and I saw what was going on. And I said, well, you know what, guys, why don't we ask Dr. Roger Hartle, who uses the brain lab machine all the time, and see what was the problem? So one of these recommendation was, let's introduce the navigated drill, which we did, right? So usually people, they put pedicle screws with this kind of like hand device, which is a pedicle finder, and it moves the patient a lot when the bone is strong, when the bone is healthy, and that moves all the navigation system as well, which end up in inaccuracy. And then it was like, but why are our screws so inaccurate? It's supposed to be accurate. It's supposed to be better. We're supposed to have 98 to 99% of accuracy based on the planning. So we ended up using instead a navigated drill with a stop, which was actually in power as well. And that made a so much better improvement because the patient wouldn't move. We wouldn't have to register all the instruments for so many times during one case. And that showed a very much decrease in terms of how much time it would take to put screws, which was about an hour then. And we were into 6 to 8 screws per patient. Now I left, and all those cases were done while I was gone or while there was no other fellow. And you can see that it took about an hour again to put 8, 10, or 6 screws. And you can see like there is a lot of variation, but it usually stays in that amount of an hour per like the whole surgery of screw placement, which is totally acceptable based on what happened before, right? And then, so that was the surgeons at Muhimbili doing their own thing with the brain lab machine, still communicating with me if there was anything to happen, showing me their screw planning, and then showing me the results on X-ray, which at the end of the day was absolutely fantastic because it worked well. And they were about 1 to 2 cases per week using the brain lab machine. When we compare, and in phase 2, they were using it 4 cases over 4 months, right? Which is once per month. So it's very, very different. And then Dr. Garveo arrived in November or so. And then the median for the screw time placement ended up lowering it to 47 minutes. Again, there's discrepancy between how many screws were put or whatsoever, but it was super fast, I think. And this is what it shows like when we have this learning curve about what happened throughout the time and over time in terms of how people improved, people got used to it. The team was built in a way that it was always the same individuals that were either showing it to other people or either just performing it themselves. So we had Dr. Mariam on site in Muhimbili that was absolutely phenomenal at teaching the nurses as to how be more efficient with the machine, as to make sure the machine would be ready for the case. And she was always there religiously at every case to make sure everything would go smoothly. And this is how you build a team. This is how it started. And I always like to show that because this is one of the first cases when I was there with them trying to use the machine. And myself, I was not somebody who was using the brain lab machine beforehand. I had used a robot. I had used another type of navigation. I had used a bunch of other technology, but not this one in particular. And even if I was there, the screws were crisscrossed, right? Which is not adequate and it's not very accurate. It's not supposed to look like that. But that was before we introduced the navigated drill. That was before so much time passed in terms of people getting so used to it and understanding the intricacies of the machine itself. And now the progress, well, now they look like that. They look like pedicle screws that are almost like a single one based on the fact that it's so well navigated and so well accurate with their placement and their planning that was done before on the machine. So that shows the growth and the learning curve as to how you can introduce this technology in the country based on different phases and obviously not being discouraged about it. one thing that was very well done is because before I arrived in the country and helped with the utilization of this brain lab machine, I made sure that I would have a training on the brain lab at the headquarters in the United States to make sure I wouldn't arrive not knowing what was going on. Obviously, there was some adjustments to be done because it's a different environment. But once you're on site and you figure it out and you ask for the help of other people that are either in Germany or in the US, I think this is something totally feasible. So this is one of the paper that we wrote as to how to develop a full partnership and to target the appropriate disease or the appropriate technology that are ready in the country to be introduced, right? So that we don't kind of like overstep or we don't go too far ahead of the curve. So, for example, before we ended up bringing a brain lab machine that was a spine navigation in Tanzania, you need to make sure that you have connection in the country. You have to make sure that you understand at least a little bit the language and the what's going on in terms of context of who are the patients. And that is why those epidemiology studies were done beforehand. That is why the partnership had been ongoing for almost 10 years before we introduced this donation. um, then you also need to know, okay, can we actually have meetings with the people on a weekly or something basis to, again, understand that we have a follow-up and we follow through the machines or the technology that can be introduced. But before introducing some sort of gold standard technology that is there to help the population and improve the care, are we sure that the basic care are taken care of? And so, and that is again the reason why this type of donation didn't happen right away, right? It took a little bit of long time before seeing it happen. And truthfully, there's a lot of places, even in the United States, that don't have a navigated machine like the Brain Lab to be able to do their screws, right? There's a lot of places in Canada that doesn't have that, a lot of places in Europe. So it is really something that is almost like inaugural, like in Tanzania, to be able to use that and become the center of spine navigation. Um, and at the end of the day, we ended up, are we having a formal training with this machine, right? Are we about at the autonomy place, a formal training to use the machine itself? And at that time, we were able to because it started small. It started with the introduction, but then the machine left the country, but then the machine arrived again and stayed there. And then there was somebody that was there continuously to make sure the machine would be used. And then there was there to make some teaching to rely on local people to make the teaching then with Dr. Mariam, Dr. Romani, and then to actually make that sustainable to stay there. And that now the surgeons, neurosurgeons, orthopedic surgeons can now use it freely within an autonomy in their own institution, which is what we're trying to get at the end of the day. There's other technologies that are making their way up in MOI as well, which is also very important to realize that didn't happen to arrive there just like this, and then we see how they're doing. So there was a need, for example, for the Vision cameras that are actually minimally invasive decompression spinal surgery. There was a potential need as well for endoscopy surgery, which was introduced last year during the course. And then there was this course during the vascular course that was actually using the technology to record the surgery and make it live for medical students that couldn't be there in the operating room in Tanzania, but could listen to it at their own leisure somewhere else. So this is what the technology introducing it in the hospital can make happen from an educational standpoint. So for example, the Vision camera, what it looks like that tiny thing here, right? It's a camera that you put on top of a tube so then you can see inside the patient without having it too big of an incision. And because at the institution, there was only one microscope available, and that microscope was usually taken for neurosurgeons that were doing the cranial stuff, right? The cranial tumor. Well, it was found that probably this camera would help to actually perform minimally invasive spine surgery. It's been studied tremendously in other countries about the minimally invasive surgery that provides decreased length of stay in the hospital provides better outcome in terms of pain and back pain because the incision is smaller, less bleeding, less infection, right? So these were all advantages that are also relatable in Tanzania. Obviously, again, we're talking about learning curve. For one level decompression, after we did all those cases, there was a median average of like 2 hours and 40 minutes to do a one level decompression. In comparison with what's happening in other countries, it's usually an hour and a half, an hour for one level decompression. So obviously that was longer, but it's also, again, this learning curve that they need to use this camera more and more to be like just getting used to it. And then the endoscopy technology that has made its way. Again, we followed the same kind of learning curve of introduction patterns with the endoscopic technology and with the actual brain lab machines. So we didn't come in and bring an endoscope to do an endoscopy spine decompression on one time and then leaving the machine there for people to use it to their own way, right? This material is costly. And if you don't know how to use it, and like, because nobody is there to train you on a longer basis, well, probably that it will become obsolete in the hospital. So we brought this machine for a training during the Global Neurosurgery course 2024. And now, as far as I know, there's going to be an amazing course of endoscopy that's happening in February 2025, where people will have more focus on the whole endoscopy technique to be able eventually to probably having the device and the instruments in the country for forever. And now they can provide endoscopic spine surgery in a way where patients will be very grateful, would be at the high point of technology, and will be sustainable. The future of what's happening, I think, at Moy is like, now that we're using the spine navigation system in a way where there's almost 40 plus cases that have been done over a year with the machine, then it's like, oh, can we use it as well for cranial, right? So I know like I've introduced a spine technology or whatsoever, but cranial is also there up in front in terms of neurosurgery. And so I know, if I'm not mistaken, that there's one hospital in the country in Tanzania that uses cranial navigation for their tumors, for biopsy or whatsoever. But now that the navigation machine is right at Moy, why not introducing some other technology that they could be useful for the patient as well? Again, just trying to strive towards more kind of gold standard techniques that are happening elsewhere that I do believe the hospital is ready for, and the surgeons especially are ready for, based on what they demonstrated using other type of technology beforehand. And like I was saying, the endoscopy course in 2025 that is organized this year, it should be a great course for everybody who's interested in trying to minimize the incisions on their patient and provide some sort of relief of pain for their patients as well. And then maybe also in the future, what is needed is a more training on the cranial frame reference that has arrived in the country. So there's a cranial frame reference for biopsy that has been given. So would this one be useful if there was more training on it, if somebody could be there to push on doing more cases and be there to show how to use it? Because sometimes those tiny little new technology, they required more training in person. And it's hard to be able to do that only with 1 week of training or 1 day of training. And I think that's one of the beauty of the fellowship with Moy and Cornell together, is that the presence of a fellow there for 1 year allows this kind of training to happen in a sustainable way because it's on a longitudinal course of time. I think it's important to talk about the sleepfrogging phenomenon, right? So recently, actually last weekend, there was the New York City minimally invasive spine surgery course that happened with Dr. Roger Hartle being kind of the lead person there. And truthfully, everything that was in this course is a bunch of like technology that are kind of like exploding in the United States and North America, in Europe. And this is kind of the technology that could be useful as well for East Africa, for more, because people have tried it, people have struggled with it, and people now have tricks with it that we can transmit in East Africa without having to like deal with all the pains of where you get towards being able to perform a surgery. So here we see Sylvia, one of the nurses in Tanzania, when she went to Cornell and was able to see what's happening over there. Same thing with Dr. Consolata over there. And this is a bunch of people at the course that were testing the AR or augmented reality technology that was also tested at Moore for one of the course. And this is what is great with the leapfrogging phenomenon, is that actually people can rely on what others have tried when they had, for example, all the equipment, but also all the personnel that was available to them. Whereas then when it comes to East Africa or Tanzania or any low and middle income country, you can actually rely on all the errors that were made before to try to not reproduce them and just better yourself on the faster track. I think in terms of team building, this is the most important thing as well, is you had people on site that were willing to truthfully use the machine and make it good for everybody and make it work and make it happen. So Dr. Zarina was part of that project, and she was pushing to get all those trauma patients to get a CT scan and get towards that machine and get their surgery done with the brain lab. And then we appointed Dr. Mariam to be there to teach nurses, to be there to deal with the machine itself, to push all the buttons and to be ready on every cases. And then we had a few residents that were actually more than involved in those cases, but were always on those cases and were teaching their colleagues, their peers, and even sometimes some of the attendings to make sure that everybody in the hospital could use the machine adequately based on all the knowledge that they had gathered through all like the pains and the mistakes that were being made, but at the end of the day, everything was successful. And that is at the Global Neurosurgery course when we were lucky to actually have the reps from every company that were there to help and teach at least 1 week during the year, where they can also give tricks to the fellow that is there and keep continuing everything in a continuous fashion. And this was at the Global Spine Congress, where we had Dr. Romani, Dr. Anthony, that were there also to present some of the results of what happened when the technology works well in Tanzania, and what kind of like impact we can make on patient care based on that, based on the fact that there was data, they were studied, and it worked. And it shows also that it's worth it to have those donations ready for the people at Moore to be able to use it on their patient and provide the care that is gold standard. I want to say thank you to everyone for listening to this webinar. Again, I'm happy to take any questions. I was lucky enough to be there for a year to meet all these fabulous people over in Tanzania, and to see that the hospital is still using the brain lab machine and the spine navigation, and that they're ready for more and ready for more technology to be involved, especially with the endoscopy. So I'm very excited to see what's going to happen in a few months based on that. So I thank you, everyone.
Awesome. Thank you so much, Dr. Cadieux, for that lovely presentation. Um, if you have questions, you can put them in the chat or raise your hand, and then we'll call on you at some point. Just to get the questions started, my first question is for this is obviously some very massive technology that was brought to Tanzania. And one issue that people always have with introducing technology is the fact that there, there's usually a need for continuous maintenance. How was this achieved with the brain lab technology for navigation?
That's a very good point. Like the maintenance, I didn't talk about it, but that's part of your team building. So it's before bringing the actual technology to the country or deciding that it's ready, you got to have the people in place to make sure that they will be ready to maintenance. And you got to ask the people from the company itself, for the company in Germany, okay, how do we maintain this? So for example, for this machine in particular, they need those spheres to be able to register like the spine with the CT and everything. So when those spheres are missing, that's part of the maintenance. That's part of that, the component of what the machine is used for. So how do you get them back? How do you get, so it's important to have the contact that if it's not me as a fellow or Martha as the fellow neck or Dr. Hartle or whatsoever, somebody has the contact in place so they can ask for more, and that there's a contract between the donated machine and the people there to say, okay, if we're missing some of those components or if it breaks, like, are we receiving the same care as somebody in North America or somebody in Europe? And that's part of the contract prior to bring that in to make sure that it's easy to receive the consumables, which for Brain Lab has been very good. In terms of maintaining it, in terms of like, is it full of dust or whatsoever, right? So again, this one is very low maintenance. We really just need to make sure that it was the appropriate plug for the electricity. So that was fitting for the African continent, right? Because it's different in Europe and North America. And then making sure that we had like a CD reader, which they made sure that they would bring. And so it's a very low maintenance machine, but that can accomplish a lot, which is why it was easy to bring in the country. I think that's where you also, like having somebody on site, you can realize, okay, do we have like the place to store it? Do we have the people to use it? Do we have like tools, just like screwdriver or something if something gets loose? And if these questions are like, no, we don't, no, we don't, no, we don't, no, well, they're probably like the institution is not ready yet to have this kind of machine, and then requires a little bit more work prior to have it arrived in the country and being used.
Oh, that's awesome. Um, so for other institutions who want to introduce new technology, um, what would you say is the general process to go about it to get companies and every other person to enable them bring in whatever technology it is?
So I think based on what my experience was and what I've seen at Moy, the fact that they had all those connections with the people beforehand kind of facilitated that. So by that, I mean, Dr. Roger Hartle was involved with a lot of company manager or whatever because of the work that he does. Um, and so what would have been great in a way is that if you're able to have uh, those connections, and by that, sometimes it's just trying to see through those websites, right? So the Right Brand Foundation is on a website. You can find out and see if it's something that your institution can fit. Through the FIENS, sometimes they do have people that you can contact through the FIENS to say, hey, this is something that could fit for us. Through Intersurgeon as well, you can have connections with other surgeons to see if it would work. And then if somebody is lucky enough to go to those WFNS, right, that exist as conferences, usually those conferences are sponsored by a bunch of companies that have the technology. And this is a good way to make connections with the people there and try to say, hey, would you be interested in coming and see our institution to see if we could be a good fit for any type of technology? But I think it's to recognize your limits and to what your institution can get or not based on the establishment itself. Because it would be great to have like an O-arm or like an MRI suite for the intraoperative surgery, but sometimes like not every institution is ready for that because it requires building new things and it's not there yet, which is totally fine. And it's not only in low and middle income countries that it's like that, it's everywhere. But I think it's just to be careful as to not bring things that are not ready to be used or that we don't know if there's a needs for it, because then they just get lost. They get lost, they don't get used. And it's kind of like disappointing for everybody that was involved in the process.
One other question I had was, so at some point in the presentation, you mentioned need for training the team of people who constantly use the navigation. So was this like a formal training? Did they have to do lectures, or it was learning on the job, or how exactly did that play out?
So for the training, actually, so I took aside Dr. Romani, Dr. Mariam, and I showed them the machine when there was no cases. So maybe like a day before, so that nobody's in a rush, there's no patient intubated on the table. And we went through the steps together. And then I did that a few weeks. And sometimes it was a resident as well. And I would tell them, okay, the CD is right here. This is what we should do. We did it last week. This week, I want you to do it. Show me how you would do it. And I'm there beside, so they can actually see how I do it, but then see how they can do it. And then I'm there if there's a question or whatsoever. And it went like gradually like that. And that's why it's great to be there for a year, because you can see the evolution of how the training is happening. Even like towards the end, I was like, okay, I'm gonna sit in the back room. You guys do it. I'm not touching anything. If you have a question, I'm there though, right? So at least there's like a little bit of a that feeling of like, okay, we're safe. There's some if something happens, like we can like salvage it. And I think that's why it's great that this 1 year training happened.
So, I don't know if there are any other questions from other participants in the chat. So there's a question in the chat. This is a great demonstration of long-term cooperation and collaboration. For hospitals trying to bring in this without such support, what do you think are the lessons you've learned from your own institute? This is from Dr. Halmangat.
Yeah, I think one of the biggest lesson is to actually not throw the towels too fast, meaning that this learning curve is a real deal and everybody needs to know about it, because it can take forever before a case go well. But if people get discouraged too fast, I think that's when it becomes sad, because it's like, oh, but can we just retry again? And can we retry and work hard? And I think that's one of the lesson here is that like make sure that everybody is on board and you find people that are very motivated. So that's why like that team building, that's one of the lesson learned is like if you don't have a champion part of that team building, it won't work. I realized that me, for example, like I don't speak Swahili very well. And I'm there for a year, so I'm not like completely long term. So that one of the lesson learned is I wish I had involved Dr. Mariam even faster, right? So that she could be involved even faster in the process, and like maybe the learning curve would have been even faster in terms of people utilizing everything. So that was one of maybe not necessarily a mistake, but I think just a realization that, oh my God, I should have bring more people faster into it to make that happen. But I think that talking with everybody though, talking, sitting down, not in the case, sitting down, a real discussion about what is going on with this machine and why don't we like it, or why do we like it or not, and then getting their input, because they're the patient, the people using it, so you got to know what they think about it truthfully.
Um, Thank you very much. Another question from George. Wonderful to see the commitment by Weill Cornell to support a fellow for a year. How likely is it that other teaching institutions will commit to something like this? Was it hard for you, given the training in the year was not necessarily equivalent to what you would have received in the US?
So I would say that how likely is that other institutions do it? Um, It's likely, but it takes some time, is my understanding, based on what Dr. Hartle started everything. So, for example, like for me to go there, obviously, it was not a mission or anything like that. So it was an actual fellowship. So there were things in place in terms of like, I needed to be fully trained to get there. And that's why, in a way, it's a very, like, I came from an institution that was WashU, where all technologies are available. Everything. You want something, it's going to be there, right? So I came from there to where somewhere there's not as much, obviously. Did I lose some part of my training? I'd say no, because truthfully, it's like riding a bike. I came back here and there's many surgeries that I didn't do for a year that I started to do again, or I went to like labs on cadavers and everything, and I kind of like got back to it. Um, if I was a little cowboy, I guess we could have tried some things in Tanzania with like more intense surgery or anything, but I don't think like the whole thing was ready there yet. So, it's not equivalent, but it's also different. And that's why they're taking a fully trained surgeon. So I didn't need more training per se to get to Tanzania. I didn't lose training per se. It was just complete different experience based on the surgeries that were done. And truthfully, I think it makes you a little bit more understanding as a surgeon as to what you're able to accomplish without all the technology, and that, yeah, you can accomplish a lot with not that much. And it's just great that you can accomplish something sometimes with the technology even, and it works. And you're like, well, that's why we're doing it, because like it looks great. So that's what I would say.
One last question from Dr. Chisaram. What service agreement is there for the equipment and long-term software updates plus training?
So there is some sort of contract that has been circulating between Dr. Hartle and the Brain Lab company when the donation happened. And in that contract, there was mention of what was given to Tanzania or more, I'd say, regarding that machine. And there's always a very friendly relationship between Dr. Hartle and the company's rep. So that we ask them, we have meetings with them, and they're always willing to, like, it's part of their deal, I'd say, that they're willing to come to Tanzania. They're willing to have at least once a year to make that happen. And I think the rest of the agreement is with the fellow itself, that I'm in charge, or Dr. Garvayo is in charge of communicating with the Brain Lab people in Germany or in the US to get what we need in terms of consumables. And they're always happy to send it because it was part of a donation equipment. There might be issues with other companies that I can't speak for, but usually they're very excited to see that their program or their device is being used elsewhere in a place where it wasn't ever before. What I think is that in the future, if these kind of software and equipment end up being kind of expanding in a lot of hospitals because they see that it's feasible and they can work there, I'm thinking that there's probably going to be rep that are going to be formed in the headquarters in Germany or whatsoever to come and work now as rep in those hospitals, and that could be possible, which would be in the future the greatest thing to see, right? Because then the surgeons would have the help of these people that have been trained with the company and that are willing to come and join the company. Because we do have reps at Moy that were for screws, but then that would be great if like these devices are so much everywhere that it's now needed to have somebody from the company on the ground. We're not there yet, but that would be the goal.
Awesome. Awesome. Thank you very much, Dr. Magalie Cadieux, for taking us through your experience with introducing technology in Tanzania. For our next webinar, with January 16th, we'll be having Dr. Hamisi Shabani from Muhimbili Orthopedic Institute take us through patient care and research in Tanzania, and what the progress has been so far. Thank you very much, and this is the end of our webinar. See you all next time.
Thank you, Anthony, and happy holidays, everybody.
Happy holidays.
Thank
Thank
you.
you.
Happy holidays.